Hello and welcome to Chapter 9, which is Legal and Ethical Concerns from the Miller Book of Gerontological Nursing. Our objectives for this lecture is going to be describe the different types of advance directives such as living wills, durable power of attorney for healthcare, and other types of advance directives, as well as discuss ethical issues that nurses commonly address when caring for older adults. Since the 1980s, legislative efforts have focused on issues related to end-of-life decisions, the rights of patients and nursing home residents, and the quality of care provided under CMS programs, which are those Medicare and Medicaid programs. Current topics of autonomy and shared decisions making are emphasized. And autonomy can be described as the personal freedom to direct one's own life as long as it does not infringe on the rights of others. Although legislation can provide us guidelines on autonomy and what an autonomous older person looks like, laws are not going to help us solve ethical dilemmas that arise when conflicts exist between decision-making abilities and advance directives. So nurses are commonly addressing questions about the extent to which an older person is able to be involved with decisions about his or her health care. In addition to these definitions, an autonomous person is able to identify a problem, search for alternatives, and select a solution that allows for personal freedom. Sometimes a person's lack of ability for decision-making or detrimental effects of their decisional outcomes may deny their inherent right or autonomy. Therefore, a loss of autonomy can mean that loss of independence, and it's a very real fear, especially in our older population. Then we talk about competency, which is the ability to fulfill one's role and handle one's affairs in a responsible manner. All adults are usually deemed to be competent by the age of 18, and unless a person is deemed incompetent by a judge, they are guaranteed all the rights granted by the United States Constitution, which includes making healthcare-related decisions. When questions arise about a person's ability to responsibly make legal decisions, as sometimes occurs with our elderly individuals or those who are critically ill and aren't thinking logically, a legally appointed surrogate assumes this decision-making capacity. Unless none is identified, so if they don't have the advance directives that we're going to talk about in the next few slides, a petition can be sent to a probate court to determine if the person is competent or not to make these medical decisions. And it gets to this point often when a healthcare professional is concerned that the appropriate decisions are unable to be made independently. So the healthcare provider brings it up to family, who usually files the petition with that probate court, and then guardianship is named from there on. However, guardianship is a last option in lieu of advance directives, because once someone is determined to have partial or full guardianship, it takes away a lot of the rights of the individual. It can take in taking away these rights, it also entails numerous court hearings and lots of monitoring. So this legal oversight and inability and loss of autonomy can be prevented by having prior legally binding documents that we're going to discuss next. Oh, I jumped ahead. First, we're going to talk about decision-making capacity. So decision-making capacity differs from competency, and that this is determined by a healthcare professional rather than a judge. And it relates to a single decision, such as one healthcare decision, rather than the ability of that person to manage all of one's affairs like finances and whatnot. One thing that could influence the perception of decision-making capacity is differing religious and cultural-based beliefs when assessing a person's rationality. For example, if you think about a patient who takes homeopathic medicine for cancer, and I've seen this in my past practice, where a patient has advanced lung cancer and they believe that a certain anti-inflammatory herbal remedy is going to cure them, that they don't have to do chemo, radiation, and or surgery, and so they believe in a miracle, and that is their belief. And how odd that sounds and how hard that is to hear as a Western trained nurse as well. So it was hard for me, and it was hard for the healthcare surgeons and doctors to really go along with this, but this wasn't an inability to make a decision. This was a decision that was based in their belief system and their cultural background. So again, sometimes decisions aren't based on logical reasons, but the person is still very competent. They understand the problem in their own way, they can have a conversation about it, and then they can communicate those decisions to others. In summary, rather than basing conclusions of decisional capacity on a person's chronological age, such as our older adults saying, oh, they're 95, that doesn't give us any reason to not listen to them. Besides of basing those conclusions on the age, diagnosis, or their logic, decisions are influenced by individual and family's needs, values, habits, emotions, and cultural factors. So here is just a quick pre-test, and then we'll talk about these. So advanced care planning is defined as a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. So what are different types of advance directives? What have you heard before? Again, we have a durable power of attorney. We have DNR orders, living wills, POLST, so physician orders for life-sustaining treatment. Something that is new to me is the 5 wishes by the Dignity Society. What is the purpose of advance directives? Well, the purpose of advance directives overall is to support the patient's rights of autonomy. And lastly, what are some cultural considerations that affect a patient's decision-making process? That can be considerations of respect for elders, autonomy, what does that mean within a culture? Autonomy versus collectivism, sanctity of life, reverence for authority, gender roles. Those are all going to influence the decisions that a person's going to make. So the Patient Self-Determination Act was made in 1991 as a legal mandate for advance directives. This piece of legislation protects patients by requiring that all providers do several things. One is to inform patients of their right to refuse treatments and healthcare decisions. 2, to provide written information about the state's provisions for implementing advance directives. 3, ask the person whether an advance directive has been completed. And 2 more. 4, include the advance directive in the medical chart. And 5, provide staff and community education to advance directives. So advanced medical directives are legal documents that allow competent older adults to document medical care they would or would not want to receive. In addition to that actual piece of paper, that directive, there is another additional paperwork such as a healthcare proxy, which names a person who would then be responsible to communicate those wishes if the patient or client becomes incompetent and unable to communicate those decisions of care. The Patient Self-Determination Act applies to all organizations that receive federal funds, which means every organization that accepts Medicare and Medicaid patients. And in the patient with dementia, in relation to advanced medical directives and advanced care planning, oftentimes in the early stages of dementia, the patient still remains competent and able to make these difficult decisions. So it's really imperative to address advanced directives before the onset of worsening cognitive abilities. The durable power of attorney for healthcare is a type of advance directive that takes effect anytime someone cannot, for any reason, provide informed consent for healthcare treatment decisions. For example, if the patient is intubated for increased length of time, or for critical illness, or if the patient or client is having deteriorating cognitive impairments. When used with other advance directives, this document can provide written instructions on a person's wishes on issues such as termination of life support measures. The healthcare proxy, so the durable power of attorney or the healthcare proxy, should have a copy of all these advance directives and periodically discuss the person's wishes, because The document is legally binding, but it can be changed and it can be modified based on a person's changing beliefs or condition. DNR is a do not resuscitate order, and it's a very specific type of advance directive that directs healthcare personnel to refrain from chest compressions or cardiopulmonary resuscitation if there's no sign of breathing and no heartbeat. But we do not want to mistake a DNR order to withhold all medical treatments. In 2000, the Reverend Chuck Myers proposed that DNR be designated allow a natural death order with the intent to replace that negative term do not with a more positive statement. And there is legislation looking at changing the DNR order to this name. Most facilities, to understand DNR, do not resuscitate, most facilities have 3 levels of resuscitation orders. One is a full code, which means life-saving measures would be indicated, such as chest compressions, cardioversion, artificial airway, intubation, etc. DNR, and in some facilities, like at CHI, we have DNR/DNI, so it stands for do not resuscitate and do not intubate. Which means that for both of these patients, chest compressions would not be indicated, nor defibrillation or cardioversion, but we could give medications to treat arrhythmias, be aggressive with our antibiotics and IV fluids. And the DNI part really comes in for patients who wish for DNR, so they don't want CPR, but maybe they think intubation is okay. And I've seen this a lot with patients with COPD. Who may come in with an acute exacerbation, and in good faith, they and their pulmonologist or healthcare professional think that intubation might help with fatigue and help them overcome an acute exacerbation. So again, there's 3 codes: the full code, the DNR/DNI, or the intermediate support, and then there's comfort cares only, which is going to be related to kind of hospice and palliative care, which we talked about last test, and which is going to include pain medications, positioning, oxygen and airway suctioning, and emotional support for patients and family members. The purpose of living wills then is to guide decisions about care provided or withheld under certain circumstances. So a major goal of living wills is to affirm the right of a person to receive or refuse treatment. A limitation in living wills is that they don't cover all foreseeable options, and a living will is different from DNR in that it identifies specific wishes, such as use of aggressive antibiotics, long-term hydration and nutrition, etc. So living wills also are limiting in that they only apply to a terminal illness. They do not apply for temporary incapacity. And so in this, I think about a patient who had a motor vehicle accident, rollover. They are unable to make those decisions for themselves, but we wouldn't enact the living will because we would hope that the situation could reverse quickly. So in this, in which, right, I think we all can kind of wrap our heads around, but unfortunately, sometimes this can lead to anoxia, brain injury, and long-term consequences. So now our living will doesn't quite apply to adding artificial nutrition, hydration, long-term intubation, trach, all the things that fall out of having brain injury and critical illness. Another form of advanced care planning is the physician orders for life-sustaining treatment, or POST directives. And these are usually put into place when the patient is terminally ill or expected to die within the next year. They are signed by the patient or a legally recognized decision maker, so the proxy. So they're either signed by the patient and a healthcare professional, which is usually their primary physician, the one who is attending or primary care. These POST orders serve as a medical order to provide or withhold treatment, and healthcare professionals are legally obligated to follow the instructions in any healthcare setting. So saying this, then, one downfall to a post order is that if these documents aren't reviewed periodically, it can lead to inaccuracy of representing the preferences of a patient as their conditions may change, which ultimately can cause us to be either more or less aggressive with their care than what the patient actually prefers. The Aging with Dignity organization utilizes a web-based format for advanced care planning, which incorporates current technology. It actually uses an e-planning website, and it provides the advanced directive in 27 different languages. And so it is used as it's used across the US and meets legal requirements as an advanced directive. It also has guides for individuals and support tools for education and multimedia materials, and it addresses any questions that patients may have for end-of-life care, such as who do you want to make care decisions for you when you can't make them? What kind of medical treatment do you want or not want? What's the level of comfort you would want? How do you want people to treat you? And what do you want your loved ones to know? The ethical issues that are present in gerontological nursing range from seemingly inconsequential concerns like when to serve meals in a long-term care facility to decisions about providing appropriate nutrition and hydration to patients. For example, let's say we have a patient that is at high risk for aspiration. Should they get a feeding tube if they're a do not resuscitate? Should they get a peg tube and go through surgery and anesthesia so that they can eat, but they're a DNR, so what happens in surgery? And it's situations like these that we call them gray. They're not black and white. It's not easy to make this decision, and it leads to a lot of stress in the medical team as well as within the caregiver and the patient. So nurses can use this holistic decision-making guide to help them through those gray or ethical decision-making times. Sometimes when we look at this holistic decision-making, those bullets on the slide there, the answers to these questions are not readily apparent, right? So we can use other tools, like on the next slide, I'm going to talk about values clarification as a way to clarify with the patient what's really important to them personally. But looking at holistic decision-making, we want to ask in the gray area. So should this patient get a PEG even though they're DNR? Am I wise and courageous enough to perceive and respect others' differences? So am I able to truly listen to my patient who might have a differing opinion of my own? What does the patient want? Really, what are their wishes? What are their personal choices? What do they want? What's their goal? Do they understand? Do we need an interpreter? Do they need extra time? Are there hearing aids in? Is the patient being coerced? So do we feel like there is something fishy, uncomfortable going on? Do we need to pull in other team members like social work, case management, physicians? So really, it helps guide us in making decisions and how to go forward to meet the patient's wishes. So the values clarification is just a tool that we can use to address ethical issues in everyday care, and it's an ongoing process. So we're constantly asking the patient, what's important, so that we get an idea and an awareness of what is their personal priorities, what is just, and why. Why are we doing this according to the patient? And to use values clarification, we need to have two skills. One is listening carefully. Okay. So listening to the patient and reflecting back and clarifying, is this what is important to you? And the second tool that we need is listing several health behaviors or values in an order of like a ranking system or prioritization, so we can meet the highest needs. Other ethical issues commonly addressed within our older adults are the use of restraints, when to implement artificial nutrition and hydration, and some other issues within long-term care settings. So regarding restraints, a physical restraint is any device, method, equipment, or medication that immobilizes or reduces the ability of a person to move freely. Oftentimes, restraints are initiated to limit or eliminate the use. Oftentimes we initiate them for patient safety, but unfortunately, restraints can amplify unsafe situations. And so there is an initiative to limit or eliminate the use of restrictive devices that can infringe upon a patient's rights and takes away their autonomy, right? So we want to reduce the use of restraints, which would require multiple interventions, multiple people, including policy change, staff education, and alternative interventions, such as pulling in family members. A lot of facilities will put rails down bed low and mattresses on the floor, things like that. But again, many institutions believe that these restraints may decrease harm, but in reality, the evidence shows that restraints are going to increase risk for fractures, delirium, soft tissue injury, and death. Related to artificial nutrition and hydration, this refers to methods of bypassing our upper GI to deliver nutritional substances due to either poor intake or an inability to swallow or chew. Oftentimes, the artificial nutrition and hydration is discussed when a patient is losing weight or it requires considerable amounts of time and assistance with feeding. Or families just have unrealistically optimistic expectations of the benefits of feeding and putting in a feeding tube. For example, evidence-based practice has concluded through multiple studies that artificial nutrition and hydration in advanced cognitive impairment such as dementia is not beneficial, and that it does not prolong life and it does not prevent suffering of the patient. Lastly, long-term care setting ethical issues are related to those that might affect the patient's autonomy, individual rights, and/or quality of life. And this might include restrictive measures to address potential risks to safety. An example of this is limiting the patient's movement because they're at high fall risk, but the patient wants to walk around freely and get up often. Another couple ideas are the restricting cigarette smoking. No smoking, but this is your home, right? That could be a potential ethical gray area. Sexual activities. Should they be allowed to have consensual sexual activities within the nursing home, and what would that look like, to a staff and policy level, right? As well as residents should be allowed to refuse any type of activity, social activity, food, fluid, etc. Some cultural aspects of our ethical issues that we come into contact with are related to religious teachings and other cultural factors that are going to have a strong influence on advanced directives, artificial nutrition and hydration, and end-of-life care. So some barriers to providing culturally competent care is that legal requirements related to advanced directives really emphasize individual autonomy. However, within Chinese American culture, this is a more family-centered decision-making tree. And Hinderer and Lee in 2009, they did a recent study that really showed that a nurse-driven intervention improved engagement in the advanced care planning process in Chinese Americans who were thought to be averse to discussing death and dying, and they have a lower than average advanced directive completion rate. But the nurses used culturally tailored interventions to improve engagement in advanced care planning and promoted the use of advanced directives. Other barriers then would be language barriers. So going back to, are we able to communicate in a language they understand so that they can participate in those complex decision-making processes? Lastly, nurses facilitate decision-making about advance directives by providing information about advance directives and care options to older adults and proxy decision makers. Nurses facilitate decisions about care of people with dementia by using evidence-based tools, such as that used in box 9.6 in your book on page 160. Here is an application ability. So the wife of your 75-year-old client comes to you with concern that her husband has decided to make himself DNR in his advance directives and does not wish to be resuscitated if his heart stops or he stops breathing. He was diagnosed in early stages of dementia last year, and she is afraid that he is not in his right mind. So what would you share with the wife in regard to his rights in the advanced care planning process? And how can the nurse help the wife in this situation? So when questions are raised about a person's ability to participate in healthcare decisions, a legally appointed surrogate decision maker assumes decision-making responsibility. In the absence of a surrogate decision maker, or when conflicts exist among people involved with making and implementing decisions, a petition can be filed, which we talked about way earlier in the probate court. Usually a family member is going to file that petition, but an attorney can also be the one to start that petition filing. And then a guardian would be awarded to that client. Most often, though, a need for guardianship can be avoided if a person makes his or her wishes known in a comprehensive and legally binding manner, including the appointment of a healthcare by proxy surrogate decision maker before any questions arise about his mental capacities. However, in the absence of these documents, when conflict arises about honoring the person's wishes, and this is when we get into our legal and ethical issues. So what would we share, with the wife in regard to his rights? It really depends on where he is. So in the core part, if there's diagnosed in early stages of dementia last year, so where was he a year ago and where is he now with his ability to make decisions? Are they logical? Can he communicate his wishes? Does he understand consequences? And so I would try to get more questions about how, the behaviors and the cognitive level of her husband within this last year. And then we would want to ask about advance directives, living will, healthcare by proxy, and see if there's any of that documentation available to help guide us in these decision-making capacities. How can we help? We want to know about the level of comfort that the patient wishes. How asking about those 5 wishes, what he wishes of the treatment team, how he wants people to treat him. So really asking, what does DNR mean to you, so that we can help determine if this is appropriate or not. So hopefully that helps. And thank you.